Good afternoon, colleagues, ladies and gentlemen. On behalf of Wendy Spearman and myself, we welcome you again to the UCT Department of Medicine COVID webinar. That's now become a regular fixture on a Wednesday afternoon. Again, we extend our gratitude to the University of New Mexico and Project ECHO for extending their license and platform for us to hold these webinars. Again, a full program this afternoon, and we shall open the chat line in the second half of the program for questions. But without further ado, I'll hand you over to your chair for the afternoon, Professor Graham Ankes. Graham.
Thanks very much, Mark. Welcome to this afternoon's webinar. We're going to start off this afternoon with a regular update on the surveillance of COVID-19 in the Western Cape from Marianne Davies, who's based at the Western Cape Department of Health and is also in the School of Public Health at UCT. So thanks very much, Marianne.
Thank you very much. Mark, I'm assuming you've got my slides, so just wait for those to go up.
They're up, Marianne.
Thank you, Mark. Our story is starting to get reassuringly similar week on week. I think everyone's now familiar with this as both Andrew and my pretty much opening slide. The arrows in these figures show where we were the last time I presented, which was 2 weeks ago. And we've seen a steady and reassuring decline, not so much in the number of tests done, but particularly in the proportion positive, which was 20% 2 weeks ago and is now down to 15%. And that's mirrored in a reduction week on week in cases, now down to less than 500 new cases a day, notwithstanding the fact that testing criteria have not changed yet. Reduced new cases in healthcare workers in the blue in the bottom center of the slide, and then in the top in the middle, reduction in daily deaths, and on the right hand side a reduction in daily admissions. In total, we have over 100,000 confirmed cases and 3,600, just over 3,600 deaths, and a total of nearly 15,500 admissions in confirmed COVID patients, and about 10,000 more if you count PUI admissions as well. And if you go to the next slide, which again, I think these are all becoming familiar, that puts all of those different metrics onto one graph. And I think it's useful to see just how well they actually track each other. So any of them is a useful indicator of where we are in the epidemic. But what I do want to point out is, for example, if you look at the oxygen use, which is the green line at the top, that although that is coming down quite reassuringly, it's still way above where we were even at the beginning of June, and we know that in fact oxygen use had ramped up even before that, and that although I think many of us are feeling some relief as the numbers decline, that we are still seeing a not insubstantial number of patients admitted and deaths per day. So things are looking better, but we're still on a relatively slow path downwards. We can move to the next slide. And this is just looking at the MRC deaths, the report that comes out today. And again, we can see that confirms the decline in deaths. We're now within the prediction interval, the upper limit of the prediction interval, but still right at the top of that limit. And we can go to the next slide. And these are my favorite plots that I subject everybody to every 2 weeks. Log of total deaths and on the horizontal axis, and log of daily deaths on the vertical axis. And there are a couple of interesting things to point out this week. If you look at the death comparing the Western Cape in blue and South Africa in red with some of the countries that we've got to know well over the last few months, the first thing is looking at the Western Cape. We continue to see a very slow and gradual drop down that indicates to us that we're moving out of exponential growth. And similar in South Africa, although probably more flat than completely going downwards for South Africa as a whole. And as I highlighted last time, because these graphs are per million, notwithstanding age and comorbidity differences between population and differences in death reporting, effectively how far to the right you drop down is an indication of how severe the epidemic has been for your country or your region. And if South Africa is starting to drop down further to the left than the Western Cape, we need to think about why that might be, and I'll be talking a little bit to that in the next couple of slides. So I just wanted to alert to that. The other thing that we see quite nicely on these slides from other countries are the second waves that you can stay with that previous slide. The second waves that we're starting to see in Spain and Belgium and several countries, and you can see the bounce up these graphs are particularly sensitive to show that bounce up. And then on the right-hand side, the red circles show where I was at the last presentation, and you can see that in our worst hit area, as we would expect, Khayelitsha and Klipfontein, that graph only came down much further to the right compared to the rest of the metro, and then in our non-metro areas, we're still in a flattening rather than actually heading downwards. And if we go to the next slide, that is shown by looking at the graphs of the cases and deaths over time, and where we're particularly still seeing not necessarily a decrease, but perhaps a peaking in deaths is in Garden Route, although it seems that the cases are now on the decline, cases in blue and deaths in red. And you can see for some of the metro areas, quite a different pattern to Khayelitsha and Klipfontein that peaked much earlier, and almost a kind of bimodal hump in some areas like Eastern and Tygerberg and Southern and Western, indicating some of the heterogeneity probably in those areas. So if these are our reported deaths, we can go to the next slide. One of the big questions has been trying to unpack the difference between the excess deaths that the MRC has been reporting and the actual reported COVID deaths from each of the different provinces. And that's shown quite nicely in these blue and red graphs. Sorry, they're kind of a bit all over the slide, where the blue line shows the excess deaths that the MRC is reporting, and the shaded red area is the proportion of those deaths that can be accounted for by provincial reporting of COVID deaths. And you can see that there's huge heterogeneity between the different provinces. In the Western Cape, the highest at about 69%, and the next provinces where there's a reasonable proportion accounted for by COVID are Gauteng at 24% in the Eastern Cape, and the rest of the provinces are much smaller. And the question is, well, are the rest of the deaths likely due to COVID or not? And one of the answers is actually shown by that heterogeneity, because it's probably plausible to think that capacity for reporting COVID deaths does in fact vary between provinces, which would suggest that some of the excess probably is due to COVID. And if we look at the difference in case fatality rates per province, which is shown in the graph at the top at the center, either taking into account a lag in reporting of deaths in orange or not taking into account a lag in blue, the case fatality rate is substantially higher in the Western Cape. And I think there's no particular reason to believe that the case fatality would be much higher in the Western Cape, which would again point to differences in reporting. And if that is the case, then the actual COVID fatalities in the country at the 4th of August, when these graphs were drawn, would have been about 2.5 times higher what was reported nationally. So about 23,000 versus just under 9,000. The next question, which we've tried to unpack, particularly in the Western Cape, if you go to the next slide, is the difference between the 70% of COVID deaths and what are the rest of the deaths, and could they be due to excess deaths from COVID-related service disruptions? And I think Graham asked Andrew this question last week, so we've tried to have a bit of a look at this. And what we're looking at here are for key conditions: diabetes, HIV, and TB. We're comparing deaths month on month from March to July in 2019 in blue. The grey are the 2020 deaths, but excluding any COVID deaths. And then the orange are all the 20 deaths, including the COVID deaths. So where the grey and the orange lines are the same height, which is in March, for all of those conditions, essentially there were no COVID deaths. And then the difference between the orange and the grey are the COVID deaths. And if we start off looking at the HIV and TB, the pattern is pretty similar, which is that in 2020, every month we saw fewer deaths if we exclude the COVID deaths. So the grey bar is much lower than the blue bar. This is most marked in May while we were still in level 4 lockdown, and then reduces somewhat in June and July. And then from June and July onwards, with the COVID deaths, you end up with the same total number of deaths, but that's because the COVID deaths are compensating for the non-COVID deaths. So it seems there's at least, well, there's certainly not a lot of evidence to suggest increased HIV and TB deaths due to disruption, and some evidence to actually suggest some benefit of increased social distancing. Although in the case of TB, it is possible that there may also be reduced diagnosis. For diabetes, the picture's a little bit different. We see the same reduction in non-COVID deaths in April and May, but the COVID deaths kick in earlier, as we would expect. And then in June and July, we do see some increase in non-COVID deaths. Given the strong association between diabetes and COVID death, it's possible that those are undiagnosed COVID cases, but it is also possible that that is due to reduced access to services, and we would need to unpack that a little bit more. And then just to highlight, this is limited to deaths that we know about in the Provincial Health Data Centre, so this is not linked to the death registry, and we may be missing some deaths in these patients. We can move to the next slide. So there was a very nice piece yesterday in Ground Up by Nathan Geffen and Alex Welt, just trying to put into context what we've seen in terms of COVID deaths in the country. And this work that's shown here is from Dave Strugnell, who is responsible for the ASA model nationally, and also just tries to put that into context. So given the number of deaths to date,
Graham, we may have lost Marianne. Graham, I think we possibly lost Marianne due to a bad connection.
I'll try and contact Marianne, and if not, then we can have the update continued next week. Just give me a chance.
I'm not sure if load shedding perhaps has kicked in some areas. Marianne, just checking if you're back.
yes, I'm here. Sorry about that.
Okay. No, I think it's possibly load shedding taken. I'm just going to carry on sharing from where you left off. So please go ahead.
Sure. So I was just saying that if we look at the two models fitted to our data, so much less pessimistic than what we've seen before. One is the ASA model in purple, where essentially the input parameters being manipulated to match our data and are not necessarily realistic, and in red, just a curve fitting model. That would give us a total of somewhere between 650 and about 800 deaths per million, which would rank us among the top 5 in the world, although acknowledging that some of these countries are now experiencing second waves, and so those rankings might change over the next few weeks and months. And the article by Nathan Geffen put this in context very nicely. So if we look at what's now realistically expected in terms of total deaths, we're probably going to see about 10% extra deaths due to COVID this year compared to a normal year, which is really nothing to be sneezed at. And in terms of the peak deaths per week, we probably saw about 6,000 extra deaths in our peak week of COVID deaths. And to put that in context, that's the same as the number of excess deaths that we saw during 2006 per week due to HIV. The big difference is that those deaths due to HIV carried on for the whole year rather than just 1 week due to COVID. And of course, they were occurring in much younger people. So the number of years of life lost was considerably more. But what we have seen has certainly not been insubstantial. We can go to the last slide. And what I wanted to do here was to try and unpack a little bit what I showed 2 weeks ago, which is that there seemed to be some hint of a reduction in mortality, certainly after June. This is in hospital mortality. So what I'm looking at here is the probability of death at 20 days, just taken as a time point by which stage most people who are going to die will have died, by week of admission, which is shown by the blue line. And what you can see is that it steadily increased until the end of May, and then there's been a fairly smooth and steady decrease thereafter. And that is despite the fact that after the end of May, we continue to see an increase in the number of patients being admitted, shown in the dashed orange line, and an increase in the proportion of patients with risk factors for mortality. So the grey line shows the proportion of diabetics, which increased over time, and the black dotted line, the proportion over the age of 60 years. And so if we adjust for those factors, the number of patients, disease severity, age, and subdistrict, the reduction in mortality after the green circle, after the end of May compared to before, is about a 35% reduction in mortality. It's hard to know what we ascribe this to. I've put onto that figure some of the key things that have happened over that period, starting from the first patient being commenced on high-flow nasal oxygen, when obviously that was ramped up over time, the opening of the different intermediate care facilities, and then the announcement of the recovery trial results. And I thought those of you on the clinical platform could probably add a whole lot of extra red arrows to that graph as we try to tease out. But whatever the cause is, we'll take good news, and nice to know that we've had a 35% reduction in mortality from our peak levels. And I'll end on that note.
Thanks very much, Marianne. If I can just ask one question, you know, when you showed the documented COVID-19 mortality and related excess deaths by the MRC, and you said that Western Cape had ascertained 69%. You know, what do you think the other 31% is attributable to? Is that, why is it not closer to 100%? Is it that that the swabs are negative, or that some other issue in the reporting system?
So those graphs, first of all, don't include the additional deaths that we actually know about that are COVID related, or at least are in patients that we have diagnosed as COVID if we link to the MRC. So those are our official reported deaths. So that would account for some of those missing deaths. And then I think you're right that there probably are a proportion, and there is some data on the proportion of patients who were swab negative and later positive. So there are some missing undiagnosed deaths. And then I mean, we can't exclude. It's very difficult to tease out, even though we've seen a reduction in non-COVID deaths. It's difficult to tease out whether, in the absence of all of our social distancing measures, you know, whether there is some effect of service disruption starting to creep in as well. And I think the other thing is that what the baseline should be for the MRC measurement is debatable. So should they be using the midpoint or the lower point?
Sorry, I lost Marianne there.
Graham, I think we've got a bit of a wonky connection this afternoon, but she did finish her sentence. Thank you.
So we'll move along then, and thank you to Marianne and for, again, a great update. Really appreciate that. Such up-to-date data to give us the full picture of what's happening in the province. So we're going to move on to our main talk from this afternoon, and that's going to be given by Marc Mendelson on the transmission of SARS-CoV-2, an update. Marc, as all of you will know, is the head of the Division of Infectious Diseases and HIV Medicine at UCT and Groote Hospital. Marc has also been the chair nationally of the Ministerial Advisory Committee that has advised the Minister of Health on clinical aspects of COVID-19 response. And Marc led the scale-up of the COVID-19 clinical services at Groote over the last 6 months, including from a day-to-day operational planning and the development of guidelines for the management and prevention of COVID within the hospital. And I just wanted to take this opportunity to acknowledge Marc's leadership role in ensuring the successful response at Groote over the last 6 months, and he continues to play a key leadership role in the hospital's response. So Marc's going to address issues around transmission, particularly the ongoing controversy surrounding the role of aerosol transmission of SARS-CoV-2 and its implication for how we go about preventing transmission of the virus. And he will also deal with the question of who is transmitting the virus. So thanks very much, Marc. I appreciate the talk this afternoon.
Thanks very much, Graham. Thanks for that introduction. And I mean, really important to say that, I mean, very kind words, but leadership and the entire COVID response has really been an amazing team effort at Groote and our affiliated hospitals, and really appreciate that and everything everyone's done. So I hope you can now see my screen and my slides. So I've been asked to really look at this issue of the evidence for SARS-CoV-2 transmission. I'm not an aerobiologist. Physics is not my strongest point, but I've tried to take an overview look at this and come up with some ideas and suggestions. So there have been, at least 8 suggested routes of transmission, predominant amongst which, as you know, have been respiratory droplet, aerosol, and contact, either direct contact or through fomites by indirect contact, contamination of hands, and then to the mucous membranes. And the first part of this talk is really to look at this and how infectious particles are generated. So up until recently, our conception about how respiratory viruses spread really came from 2 historical observations. The first was work in the 1800s by Flücher, who first was the person who highlighted droplet transmission of pathogens from droplets that were really large enough to settle around a person. And then in the 1930s, a seminal work by Wells, who really developed the differentiation between large droplets, denoted at greater than 5 microns, that tend to ballistically fall to Earth because they fell faster than they evaporated, and smaller droplets or aerosols of less than 5 microns that evaporated faster than they fell, and therefore they stayed airborne. But now in 2020, we know more, and it's got a little bit more detailed. So the initial respiratory jet includes mucus and saliva sheets, which fragment and produce really a range of particle sizes from about 0.1 to 1,000 microns in diameter. And these sheets form from a number of forces and disrupt from a number of forces, including that of breathing itself, and also from the opening and closing of bronchioles and vocal folds. And also when there are explosive expiratory events like coughing, sneezing, etc., there's violent sort of disruption of salivary droplets as well, with the tongue against the lips. And the numbers of droplets and the particles will vary depending on the explosive nature of the event. And as you can see, the numbers of droplets for a sneeze is much greater than for talking, or indeed for breathing, and their velocity as they come out is also different. So our understanding of the trajectory really and the movement of expelled particles has really advanced to taking a concept termed as sort of multi-phase turbulent gas clouds. And these gas clouds are emitted and entrap the ambient air within it. And there's a continuum of droplet sizes, as opposed to just, thinking about small and large droplets. Now, the humidity within these gas clouds allows droplets to avoid quick evaporation, and that might increase the distance that droplets will be able to travel. But eventually, small droplets will evaporate and become aerosol nuclei that may carry viruses. And how far the droplets spread depends really on a number of things. Of course, the force of the expiratory event, whether it's breathing, talking, etc. And of course, physical factors as well, such as temperature, humidity, and others. And we've come to understand that humidity really does seem to be an important in determining transmission. This very recent Australian study published yesterday really confirmed an earlier study, and one from China, that showed that humidity was important. And for every 1% decrease in humidity, there's an associated around 8% increase in the cases in this study in New South Wales. Now, decreasing humidity would favour evaporation of droplets and therefore increasing aerosols, which gives a bit of credence to the possibility of aerosol spread being important. But of course, it would also decrease the range of droplet travel. So this study does suggest that aerosols may be favoured as a potential transmission route. Sorry, I'm just trying to change to, okay. So experimentally, you can generate aerosols by nebulizing fluids which are containing the virus. And this has shown viable virus in these experimental conditions. The study on the left by Van Dormelen showing that these viable virus can be in aerosols for up to 3 hours. And then the study by Fears more recently, again, an experimental nebulization of the virus, has shown viability up to 16 hours. However, really the majority, important to say, of studies to date in clinical or in the home environments haven't demonstrated viable virus. Although in studies of other respiratory viruses, including rhinovirus and parainfluenza virus, these have been shown in aerosol-sized droplets, and viable virus has been recovered. That wasn't the case in these studies for influenza and RSV, but those were shown in slightly larger particles. So we know that respiratory viruses can be present in aerosol-sized particles. There's also been support from PCR studies. So in the clinical settings, samples that have been taken from air outlet fans in the Toronto study on the left, and from the grates of air handling grates in the study by Santapia, have both shown PCR positive. That doesn't mean viable virus, of course, but it does lend, again, credence to the possibility of small aerosols which would float upwards and therefore deposit on grates in a clinical setting. So there has been now one study last week reported from Digny and colleagues, where viable virus has been isolated from air samples collected in a room of 2 COVID patients, and these samples were collected greater than 2 meters from the patients, suggesting that these may be aerosols, and these are the cytopathic effects caused by the SARS-CoV-2 in the cultures. And so this is an example of virus which is in aerosol droplets, the first identification of this. So what about outbreaks as supporting aerosol spread? Is there evidence? Well, yes and no, really. So I'm just going to have a look at a few of these. There was a well-documented investigation of an outbreak in a restaurant in China where an index case, A1 in a family, became symptomatic just after lunching with their family and his family and 2 others nearby. And there was transmission events likely from the index case to at least one of both family B and C, and maybe more. Now, there were no the samples from the outlets or inlets of the air conditioner which showed virus there. But the idea is that potentially droplets would have been spread through the turbulent airflows. And it really, although there is a possibility that this is aerosol transmission, it's also equally possible that this is droplet transmission. And in fact, none of the staff who were in contact or other diners at these other tables, or in fact, tables further than this, were infected, which again, perhaps argues against the aerosols being a major issue. There was also a well-documented outbreak in South Korea following transmission in 27 people who were in an instructor's class, who then went off and taught various classes in multiple gyms, leading to 112 cases. And these classes were characterized by very packed rooms, small spaces. It was quite humid, which of course would increase droplet longevity, and some turbulent airflows. And interestingly, there were less transmission events in low intensity classes like Pilates and yoga. And it's clear that from studies in the operating theatre around surgical site infections, that your activity does just depend on how dispersed particles are. So the low intensity Pilates may generate far less particle disruption as opposed to the sort of very heavy gym work that you would identify with the person cartooned in the bottom right. Probably the most publicized outbreak was this outbreak in a choir in terms of the Skagit County Choir in Washington, which was put forward as an aerosol transmission event. But the choir, the members of the choir were packed very closely to each other, unmasked for prolonged periods. And there was a lot of social mixing with the opportunity for fomite and droplet spread and from aerosols. So with high secondary attack rates. So I don't think that one can say that this was aerosol transmission. This may be as likely to be droplet transmission, in fact. And just as interestingly, as an aside, you know, with singing, you're vocalizing very loudly, and we know that aerosol emissions, however, do increase with speech intensity, and that's shown. You can see in B on the left that the number of particles does very much depend on how loud people are singing. And also in the bottom, what's interesting is that there are super emitters. So people who have very high particle counts being emitted during either speaks, just saying A on the left in the bottom, or reading out a sentence in B. And there's a hypothesis that potentially superspreaders may generate superspreaders. So if you look at some of the outbreaks, again, one of the most famous ones is the church sect in Daegu in South Korea, where 3,900 secondary cases occurred from one case. And these church members are crammed together, sitting on the floor. And after every sentence of the pastor, there's a loud "Amen" shouted, and that certainly caused a big secondary outbreak. There was also in Lombardia and Iran, again, epidemiology to suggest that there's very, very rapid spread at certain points when it takes off. And it may be that these high emitters of particles and potentially virus may generate other high intensity transmitters. So you may get superspreaders from superspreaders. And in fact, there's some evidence from animal studies that potentially this may be so, but with high viral loads and high transmission events in different animal viruses. So it has to be said that the transmission of SARS-CoV-2 has not been demonstrated by the aerosol route to date. And the factors that may determine that if there is aerosol transmission is obviously the type of and the frequency of respiratory events, how those particles move through air. We've talked about the turbulent gas clouds, the environmental characteristics, and touched on humidity. And of course, what we don't know critically is what the aerosol viral load is and what the minimum infectious dose is for SARS-CoV-2. And both of these issues are going to really play importantly into trying to decide whether aerosol route really is important or not. However, there is pretty good evidence supporting direct or contact or droplet transmission from epidemiology studies, and predominantly amongst which is this WHO China joint mission study, where the majority of over 75,000 cases occurred within families, and the secondary infection rate was 3 to 10%, which is really consistent with droplet or contact rather than aerosol transmission. And also the outbreaks also favour droplet, such as the one which is described here, where really the only healthcare workers and patients that became infected in this paediatric dialysis unit were those that had face-to-face. Healthcare workers weren't wearing masks. So either they had prolonged face-to-face or they were within 2 meters. But healthcare workers outside of that range did not. And that's really, again, against aerosol transmission in this. What about the role of fomites from indirect contact? Van Dormelen's study, again, is quite famous now, shows that there are differential durations that virus can be recovered from different surfaces. So it shows that they can be on the surfaces, but of course it doesn't prove transmission. And then other modes, there's 8 modes that we talked about initially, other than the droplets, aerosols, and contact. These all are plausible, but there's very little evidence to support them, and there have been no transmission events related to these. So when do people with SARS-CoV-2 infect others? Well, from the studies of both cases in this cohort and a number of transmission pairs, the highest viral load was at the time of onset of symptoms, and it's estimated from these transmission pair studies that about almost half of secondary cases were infected from a person in the pre-symptomatic stage, and those infections would have peaked in transmission events 2 days before or 1 day after. So it seems that the height of infectivity is at the time of symptoms just before for 2 days and just after for a day. And despite there being virus by PCR detectable in the upper airways in this cohort from Würfel in Germany, they only were able to culture positive virus in people shedding up to day 8 of symptoms. So although PCR, as you know, can be prolonged in its positivity, the actual virus, transmissible virus shedding, seems to be much less than that, and only really until day 8. And that's what really is behind the evidence for our relations of isolation. So what about infected asymptomatic persons transmitting SARS-CoV-2? Well, we need to appreciate that asymptomatic people do not often stay asymptomatic, or many of them don't. And this study from a long-term care facility showed that of the people in 2 point prevalence surveys that were initially asymptomatic, thought to be asymptomatic, but 12 of them in the first, 11 of those were actually pre-symptomatic and went on to get symptoms. And in the second study, again, 15 who were put down as asymptomatic, but actually pre-symptomatic. So you've got to be careful about. However, there has been proof of principle that in that study, one of the 3 people who were definitely asymptomatic but PCR positive were able to culture infectious virus. Therefore, it is plausible that asymptomatics can transmit. Now, the true extent of asymptomatics, and therefore how much they will be a load of transmission, remains slightly unknown. But from these studies, looking at data from across different countries that are less than 20 years of age, they're generally half as susceptible as those who are over 20 years of age. And in the 10 to 19-year-olds, almost 80% of those people are either asymptomatic or have very few symptoms, so-called paucely symptomatic, compared to the much issue where only 31% in those over 70 were asymptomatic. So the total load of asymptomatics will vary depending on age, and the transmissibility will be affected by that. But estimating the overall from systematic reviews and meta-analysis, the overall likely extent of asymptomatic 12 to 18%. And it's important to notice that the secondary transmit symptomatics than for symptomatics. So although asymptomatic people can transmit, the actual transmission rate is going to be much less than those who are symptomatic. So this study from, well, interestingly, and it has implications for how we deal with people, asymptomatic people in hospitals, is that these were PCR positive patients who had been contacted with a confirmed case, and all of them were admitted to hospital, though they were asymptomatic. And 63 of those remained asymptomatic. Now, some of those had abnormal CTs and some of those had normal CTs. And both of those groups, actually, there were transmission events from them. So we know that asymptomatic persons in hospital situations can transmit, and that talks to our need for universal infection prevention. So I think the remaining questions on transmission are these, what is the relative importance of these different transmission events? That's still not worked out. Into what is the role of airborne transmissions in non-aerosol generating procedure settings, because that will talk about the masks, etc. What should be the infecting dose? What is the infecting dose of the virus? Because that's going to be important, super spreading events, etc. So lastly, I want to deal with what this tells us about personal protective equipment, really. And there have been multiple, attempts at looking at masks. Masks are a big thing, and these are some of my favorite ones. And I think, this is a really big bone of contention and big argument point. Not just for, the practicality of how you deal with enders and then the need for TB, etc., but also just in general how you set up your hospitals. So obviously, face masks can be inwardly protected. Set up between the interior of the mask, and that's important around sealing events, but also, the practicality. If with the N95s and very tight fitting, that pressure. And then if you get a good fit, then the filtration becomes important for large and small particles. The outward protection has been really stressed around community transmission and trying to get people to wear masks. These pictures are a Schlieren, it's an optical diffusion patterns. And what it shows is that particularly with explosive expiratory events, but also with breathing, there is airflow out of the mask, as we well know. And it's lateral and upwards, as well actually as forwards. The facial covering particles, but it doesn't completely reduce it through the mask. But one has to be careful to the sides of people as well. And also, when we're thinking about N95 respirators, not all are created equal. The KN95 so-called respirators are appalling and leak terribly, and therefore, do not give a good seal. So there is a definite association between universal masking in hospital environments and a reduction in healthcare worker transmission events. And this study from Massachusetts hospitals showed a mean increase in the pre-intervention period, then universal masking for healthcare workers, and then for patients decreased the healthcare worker transmission events. So there's clear evidence that this is important. And then there are multiple medical masks are non-inferior to N95s. I'm not going to go through each one of this because of time, but there is non-inferiority evidence. But that was from other viruses, not SARS, but COVID-2. But with SARS-CoV-2, this study in Naples, where the healthcare workers only used medical masks, there was one transmission event from one nurse to another nurse, but they were sisters and that happened in the home. But in all of these areas, there was no transmission, just using medical masks. Also in this Canadian study in Alberta, an estimated over 5,000 person hours of continuous healthcare worker exposure to patients with just medical masks, no nosocomial transmission events. And again, there's clinical and epidemiological evidence for the use of medical masks in certain big exposure situations, such as on an aircraft, such as in healthcare worker exposures where people were only wearing medical masks and there were, irrespective of what it is, depends on not only the PPE, the environmental controls, ventilation, others, adequate training, all the administrative things, and strict adherence to human behaviours. And there's also evidence that actually the more complicated the PPE, and particularly with many of the sort of N95s and other masks, is human failures that actually cause transmission events, both through violations of SOPs, but also just mistakes and slip-ups. So really the idea is to keep it as simple as possible. I would recommend this sort of setup, which I modeled today, and after 5 seconds almost collapsed. So keep it simple, and obviously don't do this. So in summary, what have I learned, and what do I think the take-home messages are? The whole aerobiology, the way droplets are formed and transmitted has really changed our understanding over the last few years. And we now recognize that rather than just aerosol versus large droplet, there is a continuum within these clouds. Environmental factors will play important roles. That these really are probably the major routes. One, it's impossible at the moment to say which of these routes is the predominant. I would plumb for droplet. I think aerosol transmission can occur, obviously, and I think contact, particularly indirect contact through fomites, is also important. And it really, again, speaks to what we should be doing. So generally, medical masks, surgical medical masks are enough. With social distancing, I like this graphic from McDonald's, who have socially distanced their golden arches for the COVID-19 epidemic. But really, that's our mainstay. The non-inferiority of that versus N95 respirators really does question when we should be using N95s, and really only for aerosol generating procedures. And we clearly desperately need them, obviously, for TB. And then with contact, it's about social distancing and hand hygiene. So I'm going to stop there and thank you for your attention and pass it back over to Marc.
Thanks very much, Marc, for a fantastic and really comprehensive overview of this issue that I'm sure will remain controversial. And I think your conclusion that it's likely a mix of those, and we can't get to the bottom of exactly which one is the predominant one. But the initial emphasis on droplet precautions with an emphasis on aerosol prevention in certain settings is really important message to still keep implementing, in the settings in which transmission can occur. So I want to move on to the panel discussion. And the panel today, we have two colleagues joining us. Jankie Taljaard. Jankie is the head of infectious diseases at Tygerberg Hospital and Stellenbosch University. And Pindile Gina, who is a consultant physician and works now within the division of pulmonology in the Department of Medicine at Groote Schuur and UCT, and has been working in the COVID wards over the past few months. So I wanted to turn to Jankie and ask Jankie if there was any questions or comments you wanted to make following Marc's talk.
Thanks, Graham. Thank you, Marc, for a really nice talk and a nice update. I have one or two questions, actually many questions, but to keep it short, the fact that younger people seem to have less severe disease and may be less transmissible, I'm sure that will have that must have quite a profound effect on the decisions to opening schools and the risks. I know that Sweden kept their schools open all throughout. What is your opinion in terms of opening the schools and the real risks in terms of taking the virus back home?
So thanks, Jankie. Absolutely, I would agree. I think this is further evidence to suggest that schools should be open. Very much strongly believe that. This is different to influenza, whereas influenza, where school-aged children are big drivers of influenza, and one of the potential reasons why, we quashed the influenza epidemic in the Western Cape, because really of lockdown, but the potential for kids being, kids also not transmitting, may have kept it out of the limelight. So I agree. I think there's no good reason for children not to be back at school. They tend to transmit within their peer group. The evidence for them transmitting to teachers is poor, and I think all the benefits of having the kids at school, both to the kids and the parents and society, obviously needs to come into play.
Okay, thanks, Jankie. Pindile, any comments or questions that you wanted to raise?
Thank you, Prof. Mendelson, for a very informative and clear presentation. I have two public health questions for you regarding SARS-CoV-2 aerosol transmission. For sure, we all know there are reports which have demonstrated high SARS-CoV-2 aerosols, especially in confined places with poor ventilation. One study, I'm sure you've looked at it, which was done in Wuhan, which showed high concentration of SARS-CoV-2 aerosols in patients' toilets compared to isolation and ventilated ward cubicle. Considering that as well, in our setting, when we started having the pandemic, we saw pockets of outbreaks, especially in factories and churches and post-funeral gathering, which could simply means maybe the transmission was through aerosol. What do you think could be the best way to prevent this mode of transmission over and above using mask? And the second question is, what kind of ventilation will you recommend in public places like mosques, churches, synagogues, even transportation, like taxis and buses, especially in our setting where our people are crowded?
So thanks very much, Pindile. Yeah, so that slide of all the different PPEs was really trying to address your point that personal protective equipment really is only one part of the jigsaw, the answer to reducing transmission events. So, I mean, poor ventilation is critical. As you've really pointed out, the likelihood of in winter in a full taxi to have all the windows open and protect people over and above the masks, is really problematic, and that's why there was such uproar when the government decided to bow to the union's pressure to increase to 100% in their taxis. Similarly, in the workplace, it's about ventilating, and your question about mosques and synagogues and others, religious settings and all, speaks to the findings in gyms and other areas, as you say, in the Wuhan study, which tell us we need good ventilation. Practically, if you can affect 6 to 12 air changes per hour, 12 hopefully plus, then whether you're doing that through air windows or doors, etc., or whether you're doing it through other systems, potentially air conditioning systems, but those may be potentially problematic as well, and really is, depending on the setting. But ventilation is critical, masking is critical, but it's not the answer, and it never has been. It's a suite of interventions. Infection prevention is about administrative, environmental, and personal protective controls, and you need to have all three in place.
Thanks, Pendila. Mark, can I just ask one question? I've got my camera switched off because the internet is temperamental today, so just reducing the bandwidth used. Mark, one of the arguments in favour of aerosol and evidence points would be if there was evidence that there was transmission over a long distance or separated by time. So if somebody was, for instance, infected but didn't come closer than 10 meters to another person, but a transmission occurred, or if somebody entered a room an hour or two after somebody who was infected had been in there. And you've obviously done a comprehensive review of the literature now. Is there any evidence to suggest, a long distance transmission or a transmission that occurred when people were separated in time in the same space?
Not that I've come across. I mean, it would be remiss of me to suggest that I've read all the papers that have been published on this. I have not come across any convincing evidence that there was only potential for aerosol transmission and not potential for direct either droplet or contact. I haven't come across it. Others may. If anybody has and can reference the paper, it'd be fantastic. I think I'd certainly appreciate it. But I haven't come across that, Graham. And
then, Mark, just you might have picked up and I might have missed it, but just the transmission that occurred with that choir.
Yeah.
Do you not think that is a strong evidence of aerosol? What other explanation would you posit there if it's not aerosol?
So there was huge mixing in that choir, not outside of the actual choir events at that time. So there was big setup events where and deconstruction of the hall where they took all the direct contact together, stacking chairs. There was breaks where they ate together and mingled. Plus they were standing, literally inches apart. And I think it's very difficult to say that is definitely an aerosol transmission event. Obviously, with singing and what I showed about aerosols and increasing particles, it may well be, Graham. But I don't think that it's convincing enough to say that those transmissions, even in fact any of them, were actually aerosol over droplet or contact.
Okay. So I'm going to hand back to Mark Sundrup, and Mark has some questions from the chat room.
So we've got lots of questions today. Let's see how we get through them. So the first question is, what is the frequency of asymptomatic people in Africa, given the predominantly young population? And would you speculate on how this would affect transmission patterns?
So there haven't been good studies yet from Africa in general. I mean, maybe Mary-Ann can tell us if there's any studies or if there's any data from here, but I haven't seen it. I mean, obviously with a younger population, the studies that there are using the data that there was, as I showed, they're less likely to transmit and less likely to become symptomatic. So you would expect that. However, you know, we have had over 500,000 cases, and you know the death rate has been alluded to by Mary-Ann. So, you know, it's all relative. But I guess compared to countries with a higher age of population, we are probably seeing less transmission and less symptomatic and deaths because of that, in part.
Mary-Ann, any comments from your side on?
So I also don't know of any good studies, if I can use that term. We do have some data from very opportunistically from some of the early contact tracing events where whole factories were screened or whole workplaces were screened, which suggested in the order of around 30% of people asymptomatic, and in a small proportion of those there was follow-up, and it seemed that around 18% went on to develop symptoms. We're in the process of looking at whether there are any associations between age or gender and being symptomatic, but that's limited to a working age population, so limited in terms of the variability in age. So I think what we can say is something similar to what we've seen in the rest of the world, but yeah, not certainly dramatically robust data.
Thanks. So with the lockdown being released, one of the questions with regards to domestic air travel being voluntarily available now, apparently without social distancing, so no middle seats left open, would you recommend still avoiding it as far as possible, or is the use of PPE during flights sufficient?
Look, I mean, I think you know, we're still seeing a lot of cases, and therefore I would say that if you can avoid air travel at the moment, that you still should. The aircraft example that I showed, you know, 350 people exposed, and even those exposed to the index case, 2 index cases that were within 2 meters, 2 rows of those people, none of them got SARS-CoV-2. So while I think you know, the physical distancing within the aircraft and the use of a medical mask, cloth mask, should be fine, I think one has to put it down to the fact that if you don't need to travel, don't travel. That's probably the safest advice.
And then for healthcare workers, would you advise that they wear surgical masks in their home in order to reduce asymptomatic exposure?
I think it's incredibly difficult to wear a medical mask in your home. You know, just the duration. One has to be practical. I don't think it's practical to do that. I think yeah. I just don't think it's practical. I mean, I think the only thing you can really do there is if you become symptomatic in any respect, to distance yourself in at that time. But to ask people to wear masks at home as a healthcare worker over, you know, what are you going to say in the next 6 months? It's impractical. I don't think it would work.
Another question: if irrespective turns out to be a substantial risk for transmission, would it mean that we'd have to change our infection control practices?
Well, theoretically, if you have an aerosolized virus, then well, okay, so let's just step back. I mean, again, you know, if it is aerosolized, we need to still understand what the infecting dose is and the amount of people that would be, you know, are infected in the natural environment in the healthcare setting. So, you know, it's not automatically having this finding does not automatically say that we have to change. The non-inferiority of medical masks over N95 masks in general settings suggests to me that N95, medical masks would be enough in a non-COVID ward setting where aerosolization is happening. So in our wards, C13, C12, where there's high flow oxygen, which is, you know, an aerosolizing procedure, albeit not as great as was initially feared, then I think there is some rationale for N95 respirator use. Outside of that, I think a medical mask would be enough.
Thanks. And then an interesting question, does the strain of COVID-19 determine whether a patient will be symptomatic or asymptomatic?
We don't know that at the moment, and partly I think we don't know that because there hasn't been such a degree of strain variation that we would be able to know that. Mostly the big outbreaks are clonal strains, and therefore you're seeing you're seeing both symptomatic and asymptomatics. If it was a virus that mutated, highly mutated, rapidly, you would probably be able to tell that, but I don't think we don't have that information at the moment, and I'm not sure that we're going to be able to get that readily.
And in terms of high flow nasal oxygen, what is the risk of aerosolization in that setting?
Look, there was a concern, and there are people on the call, including Pendile, on our panel, who's probably much better to answer that. I can't answer it in terms of actual statistics, but I can say to you that there was certainly a very marked concern early on, but I can't remember what the numbers were from the paper. Perhaps Pendile or one of the respiratory specialists on the line might be able to help us with that.
Pendile?
What was the question again?
So the risk of aerosolization on high flow nasal oxygen.
It's been reported in multiple papers that there's high aerosol exposure with high flow. Yeah.
Yeah, if I could just add that, there was the one paper in the European Respiratory Journal that compared high flow nasal oxygen to other oxygen delivery and looked at the production of infectious droplets, comparing face mask oxygen to high flow. And it didn't seem to be a much higher risk than other forms of oxygen delivery. So that was one of the reasons why, we moved ahead to providing it in the COVID wards, but obviously with N95s as precaution.
So one last question, what is the risk of people who play wind instruments? Do you recommend that they are in their own room? How do they practice?
Probably from an oboe player, Mark.
Actually, I haven't seen that, but I did see a paper on safe singing, which was wonderful. And in fact, the safest singing, of course, was over a Zoom, a Zoom choir, which didn't really require a paper to play that. Whereas rock concerts were the worst. I would suggest that that probably any wind instrument that required significant pressure to build up in the expiratory phase would almost certainly cause aerosolization and droplet spread. And therefore, Wendy, when you're in your quartet, I would suggest.
Thank you, Graham.
Sorry, I see there's one question from Linda Gale Becker saying, are we addressing ventilation sufficiently? Aerobiologists seem to be more strongly favouring aerosol transmission. They've become more and more vocal. So what do you think about the issue of ventilation in a community setting?
Look, as said, ventilation is the environmental control of infection is absolutely central, and the problem is that so many of the high-risk settings that our population is is going to come across, and particularly in transport has been highlighted, but in many others, is really problematic. And no, I don't think that we're taking a ventilation into account in a proper way in our wards. I mean, obviously we're doing as best we can. I mean, in our wards, remember, we're not predominantly, we're not isolating people in single cubicles even, let alone trying to improve ventilation in general. So I think there's an awful lot more to do, and perhaps the COVID-19 epidemic in South Africa might generate a bit more interest in our hospital and health institution setups, also our clinics, and how ventilation is important. I mean, we battle with this, and you particularly, Linda Gale, and others battle with this every day in TB. But I think this has highlighted again the importance of respiratory pathogens in particular, and how we need to get administrative and environmental controls really set up. Otherwise, the PPE really is much of a muchness. It's these other things where there's big bang for your buck.
Great. So just to finish up then, just to say thank you again to Marc, to Marianne, the panel members, Yankee and Pendila. We will be having another webinar next week, Wednesday, that will be focused on the epidemiology, but looking beyond the Western Cape at a national level, the epidemic across South Africa, with our main guest being Kerrigan McCarthy from the NICD, who will conduct the webinar together with Andrew Bull and Marianne Davies from the Western Cape. So back to you, Marc and Wendy.
Thank you, Graham, and thank you, everyone. We'll see you next week. And again, as we have noted before, a big thank you to our back-end colleagues who make this all happen, Karen Fenton and Cheryl Valentine from Project ECHO and Gastro Foundation, as well as to Sahana Rangel and Clay Jeffrey from the Department of Medicine. Thank you very much, and we'll see you next week.